Good afternoon. Myself, Dr. Sangeeta Jana. I'm consultant gastroenterology at Kailash Hospital and Neuro Institute, Sector 71, Noida. I welcome you to this conversation of today. In the month of April, we know that is IBS month. So today the topic of discussion will be IBS. I regret that my colleague Dr. Piyush is unavailable today because of an emergency. So, briefly, we know that IBS is becoming more and more common. What is IBS? Irritable Bowel Syndrome. So, first, let me take through the discussion, starting with definition. As per the Rome Code criteria, irritable bowel syndrome is defined as pain abdomen at least occurring one day in a week for last 3 months, and that should be related to defecation, related to a change in the form of stool, and related to the change in appearance of stool. So most of the patients usually, when they come to us with pain abdomen that is associated with some bowel movement. So what do I mean by the form of stool? That is the standard is the Bristol stool form chart, where we have stool forms 1 and 2. 1 being pellet-like stools, 2 is hard lumpy stool with cracks, and 6 and 7 is the other end of the spectrum, that is fluffy blobs of stool, and 7 is just watery stool. In between 4 and 5 is smooth sausage-shaped stool, that is the normal. So when there is a change in this form of stool, either it is 1 or 2, that is towards the constipation side, or it can be towards 6 and 7, that is towards the diarrhea side. If it is occurring more than 25% of the time of defecation for a patient, say Bristol stool form 1 and 2, then we will label it as irritable bowel syndrome in category of IBS constipation type. And or it can be less than 25% of the time the stool form is Bristol stool form 6 and 7. Similarly, if it is towards the watery end, that is Bristol stool form 6 and 7 is occurring more than 25% of the time, or the constipation end, that is Bristol stool form 1 and 2 is occurring less than 25%, then that goes into the subtype of irritable bowel syndrome diarrhea type. So this is the two main types that we can briefly understand. Other than this, there can be a mixed type, which is the most common one. Most of the patients have a mixture of either constipation and diarrhea, where it is more than 25% times Bristol stool form 1 and 2, and more than 25% times stool form 6 and 7. Or sometimes it doesn't fit any of the above, then it is IBS view, that is irritable bowel syndrome undetermined. Now, coming to the next part of the definition, that is the appearance, change in the frequency of stool. So, usually patients come to us with a complaint that they have abnormally high number of stool passage, especially characteristically in the day. And I emphasize this point that usually nocturnal increased frequency is not seen in patients with irritable bowel syndrome. If there is nocturnal increased frequency also, that indicates more of an organic pathology, and then we should focus on thinking of organic etiologies as a priority. So this is what I mean with the frequency of stool. Similarly, in the constipation type, they have usually complaints of less frequency of stool. So next is this abdominal pain. Earlier, it was not a part of, it was not mandatory for definition, but now it has become mandatory for definition. So these patients definitely complain of abdominal pain. Next is that what do I mean by organic and what do I mean by functional? So irritable bowel syndrome usually comes in the category of functional bowel disorders. That means there is some component of psychological factor and associated with this disease. So recently a lot of emphasis and research has been done indicating the role of gut microbiota, and there is a gut-brain axis. So it was just a hypothesis earlier, but now there is a lot of studies to indicate that there is an established gut-brain association. That is why irritable bowel syndrome, even in the management part, we take care of the psychotherapies and to address this functional component of the patient. So when we approach the patient to come to a diagnosis, first we must rule out that for sure there is no organic pathology residing in a particular patient before labeling him or her as a patient of irritable bowel syndrome. So in the workup, First of all, we must rule out celiac disease, for which we can do simple blood tests like IgA tissue transglutaminase test. Of course, we'll do the other complete blood test as in routine tests for the patients like thyroid profile, sugar, because even these metabolic factors sometimes lead to altered bowel habits. Like thyroid patients can have constipation, hyperthyroid patients can have diarrhea. Similarly, diabetes mellitus disease per se or the medications given for the disease also alter bowel frequency form. So we must do basic blood tests and liver function test, kidney function test, viral markers. So after completing these tests, then we progress to next sequence of tests. A point to mention here that do we need to do stool routine test of enteric pathogens for all these patients of irritable bowel syndrome? Well, as per the ACG guidelines and European guidelines, routine stool testing for enteric pathogens is not required for IBS. What about ultrasound abdomen? Because the patient will primarily come for abdominal pain, yes, ultrasound abdomen has to be done. What about colonoscopy? Colonoscopy, if everything else has been found to be normal and ruled out, then we must also go for a colonoscopy to see whether there is any organic pathology residing in the bowel. Also, pelvic floor disorders and rectal disorders should be tested, and we can do manometry or we can do pelvic floor testing to come to the conclusion of irritable bowel syndrome after excluding such disorders. Next is fecal calprotectin. Fecal calprotectin, fecal lactoferrin, C-reactive protein. Well, these are also easy tests to first go with these tests before diving into colonoscopy. Because if fecal calprotectin is elevated, then we can have an indication that the patient can have underlying irritable bowel, inflammatory bowel disorder, that is IBD. And if fecal calprotectin is less than 50, then we can take a conclusion of the likely possibility of irritable bowel syndrome. So, coming to the pathogenesis of this condition, a lot of hypotheses and etiologies have been discussed upon for irritable bowel syndrome, but there is no one particular etiology which is associated with irritable bowel syndrome. So, there is visceral hypersensitivity, which is why patients have enhanced pain perception. Also, there is increased intestinal permeability has been postulated. There is alterations of gut microbiota, as I have discussed earlier. There is also a post-infectious, acute infectious IBS mentioned. That happens after a small transient episode of acute enteritis, followed by irritable bowel syndrome. So, even there is an influence of microbiota into this disorder. There is even psychosocial stress, which is very prominent these days in the lifestyle of most of the patients. Also attributes to improper sleep, improper gut health, and also predisposes to the development of irritable bowel syndrome. So, when the patient comes to us, we diagnose irritable bowel syndrome. It is to be explained that this is a long, this disease will have a long course, and so patient compliance is necessary. Patient understanding of their disease is necessary. We have to educate them and give them that psychological support, and the psychotherapies are there dedicated psychotherapies for irritable bowel syndrome. Plus, after that, a medical support has to be also given. In the medical support, peppermint oil has been approved among the it is not a cutting cut pharmacological therapy, but peppermint oil has been postulated to act on L-type calcium channels, and thereby it reduces pain, and also other mechanisms whereby it relieves the pain in irritable bowel syndrome patients and can be given. It is approved. What about the role of probiotics? Well, probiotics, as per the guidelines, is not recommended for irritable bowel syndrome. However, probiotics sometimes is given on a trial basis and also has to be shown to be beneficial in some studies, but sometimes it is neutral or non-beneficial. So, as per the American guidelines, it is not recommended for irritable bowel syndrome per se. What about the role of fiber? Now, a lot of discussion and emphasis has been given these days about fiber. Even PVC ads are also focusing the dietary fiber is to be taken, and Yes, definitely fiber has multiple role, not only in irritable bowel syndrome but also many other spectrum of diseases. But patients should not be confused as to what fiber they should take, because soluble fiber, that is mainly psyllium, is beneficial for irritable bowel syndrome. However, insoluble fiber will cause more of water retention, fermentation, production of more gases, short chain fatty acids, and thereby exacerbation of symptoms. So it is not insoluble fiber, but it is to remember that soluble fiber is to be taken and is beneficial for irritable bowel syndrome. Now, particularly for the constipation subtype, there are some medications like chloride channel activators. We have lubiprostone, which is advised as 8 micrograms twice a day. That activates chloride channel, increases water secretion into the colon, increases the bulk and softness of stool, so thereby helping the patients with IBS constipation. Also, newer drugs like guanylate cyclase C activators, linaclotide, precanatide, that is also approved for irritable bowel syndrome constipation type. Then we can go for 5-HT4 agonist tegaserol, but earlier it was scrapped even from the market because there were cardiovascular adverse events. However, it has come back in the use of irritable bowel syndrome. But a word of caution is it is to be used in women less than 65 years of age with less than one cardiovascular risk factor. And for the diarrhea subtype, for diarrhea subtype, we have to use fibers, we have to use these psychotherapies, and also there is a role of rifaximin, which is a non-absorbable antibiotic. It also has been shown to help in the subtype of irritable bowel syndrome, diarrhea subtype. Is there a role of polyethylene glycol? However, as per the guidelines, there is no role of polyethylene glycol. Now, patients commonly ask what kind of food they should take. So, in lifestyle modification, important note should be made is to decrease the intake of FODMAPs, that is fermentable oligosaccharide, disaccharide, polyols, monols. And for that, they should take a dedicated visit to GI dietitian to go through the list of food that they should eliminate from their diet, because it is many studies have been seen and guidelines have approved that a low FODMAP diet definitely is beneficial as a treatment for irritable bowel syndrome. Similarly, there is psychotherapies also that are dedicated for the treatment of irritable bowel syndrome with good results. They can be, but however, it is not that common and not available in many of the hospitals as of yet. Um, with more and more awareness, patient compliance, patient education, patient being free to their doctor to come and go through whatever is their concerns, proper patient education, we can tackle irritable bowel syndrome and take this disease more frequently, diagnose it and treat it. With that, I would like to take on questions, if any, on this topic. Yeah. So, first question that I see is what kind of food would you recommend for irritable bowel syndrome treatment, and is this curable? So, food, as I said, food that cause a lot of bloating. So, junk food with trans fat, excessive spicy food, excessive oily food. Obviously, that has to be avoided, as everybody knows. But specifically for irritable bowel syndrome, FODMAPs has to be decreased. And by FODMAP, I mean fermentable oligosaccharide, disaccharide, polysaccharide, and monosaccharides. And is this curable? Well, this is curable means the disease is gone. So this is a lifestyle condition which is gonna be there for long. It is not totally curable, but it is manageable. And if patient understands the condition and with repeated visits with the doctor and eventually even the psychotherapies, it can be taken care of very well. Next is, can IBS lead to other diseases such as inflammatory bowel disease or cancer? Thankfully, this is a totally benign condition. It does not change into cancer. It does not change into inflammatory bowel disease. Next question is IBS the same as IBD? No, they're totally different conditions. Irritable bowel syndrome is a functional condition, whereas inflammatory bowel disease per se is a organic condition. It again has further subtypes: ulcerative colitis, Crohn's disease, IBD, undetermined fetal, childhood IBD types, that is the pediatric patients. So unclassified. So irritable bowel disease and inflammatory bowel disease, they are totally separate diseases, and they have nothing to do with this. Is this condition genetic? Well, yes, there is no one particular gene that is attributed to irritable bowel syndrome, but there is a influence of gene studies have seen that people in the family who have irritable bowel syndrome, many of the family members also tend to have it. So yes, it is multifactorial and genetics also have a role to play. Then this will, doctor, what is the main cause of irritable bowel syndrome? Yes, what is the main cause means, again we have to ascribe one etiology to irritable bowel syndrome, and there is no particular one etiology or one main cause that attributes to irritable bowel syndrome. However, as I said, it is multifactorial. That means in our bowel there are many receptors and channels which get altered, especially the attack calcium channels which are there for pain modulation. They are affected. There is visceral hypersensitivity that has been attributed to irritable bowel syndrome. Then there is increased permeability. There is gut microbiota dysfunction. There is alteration of the microbiota that exists. There is a difference. However, there is no rule of fecal microbiota transplantation. That is not approved as of yet for irritable bowel syndrome. Um, next, next question that has been asked: if you eat a proper diet, you won't be sick. Please use homemade food, it's good for you. Yeah, that is very good suggestion. More water intake, clean food, clean water, and a homemade healthy diet with lots of fiber, soluble fiber, and salads. Not ready to eat junk food, not trans fat. That is, of course, healthy. What test would you recommend for this? Yes, as I went through the list, we will go through the complete hemogram, liver function test, kidney function test, amylase, lipase, blood sugars, thyroid profile, the routine investigations. In addition, we must do a tissue transglutaminase test to rule out celiac disease. And in the stool, we must check for fecal calprotectin or fecal lactoferrin and CRP to rule out inflammatory bowel disease. Then we have to go for special tests like anal manometry to exclude pelvic floor disorder, anal or anal sphincter disorders, and eventually we can go for colonoscopy to rule out other organic colonic pathologies like polyps, mass, malignancies, ulcers, stricture, inflammatory bowel disease. So all of this can be excluded with a colonoscopy. So these are the tests that is recommended for irritable bowel syndrome. I think. Can we prevent irritable bowel syndrome? Yes, that's a nice question. We can definitely prevent irritable bowel syndrome by being more conscious of it, aware of it with such discussions, so that patient can identify that increased frequency in stool, the increased form in stool, or the pain abdomen is not to be just sit with it and forget about it. Come see a specialist gastroenterologist for this, discuss, address your concerns, and then that proper counseling, proper evaluation, and if required medication, dietary modifications, that will help. Also for prevention purpose per se, to decrease the day-to-day psychological stress also helps. Taking healthy food, taking healthy meals, that will also help in balance, keep a good balance of the gut microbiota within. And these things I think can help in the prevention of this condition. What can trigger irritable bowel syndrome in children? Particularly, there is no trigger factor except for I can recall that acute infectious IBS. That is, after some travel or after some unhygienic food or water consumption, a short acute episode of enteritis that predisposes to irritable bowel syndrome. That can be a trigger, but that is not exclusive to children. It can happen in adults also. So this can be a trigger to irritable bowel syndrome. I think that addresses all the questions. Some more questions. I hope you had a we had a good discussion. Thank you.